Good morning, everyone. I'm Dr. Rohit Kinde. I will be presenting my paper on structure-function relationship and diagnostic value of macular ganglion cell complex measurement using Fourier domain optical coherence tomography in glaucoma.
Sorry. I'll take
Standard
it from you.
automated
Keep it. I'll
perimetry has
take it
been
from you.
widely used to assess visual function in glaucomatous eyes for staging and monitoring the disease progression. It has been estimated that at least 25 to 35% of retinal ganglion cells must be lost before producing significant abnormalities on visual field. Therefore, developing methods to quantify retinal ganglion cells related to glaucomatous damage changes could lead to glaucoma detection at an earlier stage and more accurate tracking of glaucoma progression. Optical coherence tomography allows for non-invasive imaging of glaucomatous structural damage involving optic nerve, peripapillary retinal nerve fiber layer, and macular region. Macular ganglion cell complex includes all innermost retinal layers potentially involved in glaucomatous damage: RNFL, ganglion cell layer, and inner plexiform layer. My objectives were to evaluate relationship between visual function and macular ganglion cell complex thickness measured by FD-OCT. And another objective was to evaluate the diagnostic value of macular ganglion cell measurement comparing to RNFL thickness and macular thickness using FD-OCT in detecting early, moderate, and severe glaucoma. It was an observational cross-sectional study carried out at tertiary eye care center in central India over 18 months. Minimum sample size required per group was 35, and regression analysis and ROC curves were used for statistical analysis. Eyes without any relevant abnormal ocular history or examination and eyes having primary open angle glaucoma were included, while eyes with angle closure glaucoma and secondary glaucoma, eyes with any ocular pathology, or eyes with myopia worse than -6 diopters were excluded. Eyes were grouped into primary open angle glaucoma and normal group. Further, they were classified according to modified HODAP Anderson Parish grading scale into early, moderate, and severe glaucoma. All subjects underwent the following examinations during a single day: slit lamp examination, applanation tonometry using Perkins tonometry, gonioscopy, fundus examination with indirect, direct, and slit lamp biomicroscopy using 90D, automated refractometry, standard visual field testing, and FD-OCT after pupillary dilatation. Results: 84 eyes were included, of which glaucomatous were 42 and normal were 42, early were 12, moderate were 2, 12, and severe were 18. As the severity of glaucoma increases, the mean deviation and pattern standard deviation increases significantly, while RNFL thickness decreases significantly as the severity of glaucoma increases. GCC thickness decreases significantly as the severity of glaucoma increases. However, in patients with glaucoma patients, as the severity of glaucoma increases, macular thickness does not decrease significantly. As can be seen here, peripapillary RNFL thickness and macular GCC thickness had similar structure-function relationship with visual field sensitivity, best explained by curvilinear functions of regression analysis. Similarly, peripapillary RNFL thickness and macular thickness had similar structure-function relationship with visual field sensitivity, that is pattern standard deviation, best explained by curvilinear functions of regression models. Macular thickness did not yield stronger structure function association. While considering diagnostic values, early glaucoma, the diagnostic value of mean GCC was greater than that of the mean RNFL, but difference was not statistically significant. The diagnostic value of mean GCC and that of mean RNFL were greater than that of macular thickness. Inferior RNFL was best able to diagnose the early glaucoma, while in moderate glaucoma, the diagnostic value of macular thickness was greater than that of the mean RNFL thickness, which was better than that of the mean GCC. Superior RNFL thickness was best able to diagnose the moderate glaucoma. For severe glaucoma, GLV was best able to diagnose the severe glaucoma when macular thickness compared to mean GCC thickness and mean RNFL thickness. Macular thickness had greater diagnostic value, but this discrimination in diagnostic value between macular mean GCC thickness and mean RNFL thickness is not better than by chance. The results of this study for RNFL and mean GCC thickness were in conformity to the previous studies. However, there are no studies which have compared these results with macular thickness. In our macular study thickness, macular thickness was able to diagnose moderate and severe glaucoma better than the RNFL and GCC thickness. This could be explained with the floor effect. In conclusion, I would like to say that relationship between visual field sensitivity and GCC was best explained by curvilinear functions of regression models. Mean RNFL and mean GCC thickness had similar diagnostic value for early glaucoma, but not better than macular thickness. And mean macular thickness was better for moderate glaucoma, while for severe glaucoma, GLOV was best able to diagnose the severe glaucoma. Under limitations, I would like to say that this was a cross-sectional study, sample size was relatively small, and further larger studies are required to endorse the study results. These are my references, and thank you so much.
Thank you very much. Would any of the colleagues have some questions? So I just want to ask you that you considered macular thickness as a parameter because you're comparing with ganglion cell thickness, and
Yes.
it's a rather dull parameter. other thing that is that you mentioned that GCC thickness was inferior to RNFL thickness for the detection of moderate glaucoma. So I don't know whether you actually took a look at the deviation maps of ganglion cell, because that's the first thing that you will see. And deviation map, if you have moderate degree of RNFL loss, the deviation map of ganglion cell loss would just show you significant loss. So I don't know whether it had something to do with the machine and whether it didn't give you the the retinal
Yes, sir.
deviation maps, and so you couldn't
The-
but that's something you need to go back and
Yes.
take a look at once again.
Yes. Thank you.
Just one question. As sir said that you included the macular thickness. Now, what was the rationale of including the macular thickness? Did you expect that it will change in the glaucoma? Because we are already using very specifically GCC.
Yes. Just for comparison reason, while considering
It's
all
not
the
s-
three letters or the
You
three
can just
parameters.
in GCC also we use the glaucoma complex, this thing cells.
Yes.
We use the ganglion cell, we use the RNFL, but where is exactly what we need is just simply the GCC we want to know. But since we can't measure that, the instrumentation is such that we cannot measure that simple layer. So there's a problem in measuring that. So all the three layers are measured usually. And then to include all the layers of the macula, I mean, that's a bit, I can't expect.
Yeah,
All
then
right.
this
Thank you. We got the gist actually. Thank you so much.
Thank you.